Good morning. Today we'll be talking about haemophilia, understanding haemophilia and other bleeding disorders. Bleeding disorders, unfortunately, are things that are quite common in Nigeria, but a lot of people don't know about them and the problems that they cause. So we're hoping to unravel that in this program. Good morning, Professor Akanmu and Megan. Thank you so much for coming on the program. It's a pleasure to have both of you here with us.
Good morning.
Good morning, Dr. Pamela.
Morning, it's a pleasure. So, talking about haemophilia, I'm going to start off with Prof. I know you have a lot to say, Megan, but I'd just like to start off with Prof, just going through some of the technical details. Prof, can you tell us what is a bleeding disorder and what is haemophilia and why do we, as Nigerians, need to know about it?
Thank you very much. Bleeding disorder implies that an individual who ordinarily should not be letting out blood from his body is letting out blood from the body. It's an abnormality of a terminology we refer to as hemostasis, what God Almighty has given to us to ensure that when our blood is within the blood vessel, it remains as a fluid state, or when any damage or injury is done to our blood vessel, that the blood does not continuously leak out. The blood should be able to form a clot and stop the bleeding. When you have an abnormality that does not allow your blood to turn to a clot, then we will say you have a bleeding disorder. And that's a big problem. And that bleeding disorder, we classify it into two. We say you may have what we call coagulant bleeding, or we say you have what we may call vascular bleeding. We say you have a coagulant bleeding when one of the several proteins that participate in the mechanism that allow the blood to turn to a clot is deficient. Then you have a coagulant bleeding disorder. We say you have a vascular bleeding disorder when a number of factors that allow the blood vessel to shrink and prevent blood from leaking out, when one of those factors are abnormal, then you are going to have vascular bleeding. If you have deficiencies of the structures of the blood vessel itself, or you have a deficiency of a protein they call von Willebrand factor, or you have a deficiency of a particular cell in the blood we call platelet. Platelet abnormality, platelet deficiency, abnormality of structures of the blood vessels, any abnormality in those areas will give you what we call vascular bleeding. And there are different clinical presentations of vascular bleeding as opposed to coagulant bleeding. When an individual has what we call vascular bleeding, they tend to bleed primarily into the skin. But when an individual has what we call coagulant bleeding, they tend to bleed into the muscle, they bleed into the joint, sometimes they bleed into the urine, sometimes they bleed into the stool. A variety of bleeding do occur when an individual has coagulant bleeding. But of all the proteins that can cause coagulant bleeding, two particular proteins are very common. That's what you call factor 8 deficiency, factor 9 deficiency. So when an individual has a deficiency of factor 8, we will say this individual has haemophilia A. When an individual has a deficiency of factor 9, we say this individual has haemophilia B. And there is a third type of haemophilia that's not very common. We call it haemophilia C. That is when an individual has a deficiency of what we call factor 11. Let's stop here for now.
Oh, wow. I think that's very engaging, and I think that's but a bit complex for people. So if I may just, can I simply say that there are two kinds of bleeding, the vessel one and the coagulant one, and basically it can be distinguished, but all of them are bleeding disorders and need to be understood. Am I correct?
Thank you very much for simplifying it.
So thank you. So I think what we actually want to talk a bit more about is hemophilia, because hemophilia, which is the coagulant one that you explained, seems to be the most common type in Nigeria. Am I correct? So how do we know which one is hemophilia, A, B, or C? Does it really matter? I have Mrs. Megan, who's here, going to be talking to us about the Hemophilia Society. But can you tell us a bit more about hemophilia and how does it come about? And who gets it, who doesn't get it, and how is it passed on? Is it passed on within a family? Can it start de novo? I know I'm asking so many questions, but people need to know.
Is that question for me or for Prof?
Prof.
Okay. So,
All right. Hemophilia A is a deficiency of a protein we call factor 8. That is very clear. And it is common in all populations. We have on record that 1 out of every 10,000 to 1 out of every 11,000 members of a population is likely going to be an hemophiliac. So if we assume that 1 out of every 10,000 members of our population will be an hemophiliac, and we have up to 200 million Nigerians, you should expect that about 20,000 Nigerians carry hemophiliac gene and should be hemophiliac. You will ask Mrs. Megan, and it will tell you that of the expected 20,000 hemophilic Nigerians, how many have we been able to diagnose? And it is not true that a particular population is at higher risk of having hemophilia cases. It is not true at all. The hemophilia gene has been found to be like that across all populations that have been studied. The other hemophilia, which is hemophilia B, the prevalence is a lot lower than that of, in fact, they say out of every 10 hemophiliacs that you find, up to about 8 or 9 will be hemophilia A, and only about 1 will be hemophilia B. And the other type of hemophilia that they call hemophilia C is extremely very rare. The hemophilia gene, that is the gene that transmits, the gene that can be abnormal, or the gene that is usually abnormal, that causes hemophilia A. That particular gene is on chromosome X, it's on sex chromosome X, so that it is the abnormality of that particular gene on chromosome X that is the major problem. And that is why we say that males are at higher risk of becoming an hemophiliac. The reason being that females have 2 X chromosomes. So when one of the X chromosomes carries the hemophilic gene, the other X chromosome is normal. It's very rare for you to have a female that will have the 2 X chromosomes to carry hemophilic genes. That is why the male is usually the one that will find out clinically to suffer hemophilic bleeding. Because when the mother transmits a chromosome that has hemophilic gene on it, and the father transmits the Y chromosome, so the male has only one S chromosome, and that S chromosome is abnormal. So the male will be an hemophiliac. But the carrier that actually transmits the gene to the male child is usually free, except that woman has what we call lionization. Don't mind my English again, or the terminology. Lionization.
It's very complex.
Yeah, because you can have a female hemophiliac too. We say it has one S chromosome that carries the abnormal gene, but the other S chromosome is normal. But it is possible in what we call lionization theory, or you see, you have 2 S chromosomes, and the female tend to naturally inactivate one of the S chromosomes. If you unfortunately inactivate more of the normal chromosomes, and you now have more of the X chromosome and one of the chromosomes that carries the hemophilic gene to be in abundance, then you may also suffer from hemophilia. That's what we call lionized hemophilia. It is rare that a female will be born with 2 X chromosomes that carry hemophilic gene, meaning that you have an hemophilic father who transmits abnormal X chromosome to you, and you also have a mother that has a carrier that's also a carrier and also transmits a hemophilic chromosome to them. You now have a female that have 2 of her X chromosomes. The 2 of her X chromosomes carry hemophilic gene. That scenario is very rare, but has been reported.
If I can ask a question.
Just one last sentence there, that an hemophilia can occur de novo. That's also true. De novo means that you didn't, you have a female carrier who did not inherit the abnormal X chromosome from our own parents. The parents have normal X chromosome, but you now have this female that has hemophilic X chromosome. That actually happened during the making of that female. A mutation occur during when the sperm and the ovum are meeting in that particular female. A mutation does occur, and that actually occurs in 1 in 3 of all X, in 1 in 3 of all female carriers. So that if you are looking into family history and you do not see a family tree that shows that somebody has been an hemophiliac, don't be surprised, because hemophilic mutation does occur 1 in 3 of all hemophilic situations. This is why we say de novo hemophilia is also not rare.
Wow, that's very powerful. So very simply put, yes, there are some cases with a family history, and yes, there are some cases that appear de novo, and so it cannot be ruled out just because there's no family history in that particular family. Thank you very much. Thank you very much for coming back on the program. I think this is, we've just sort of ironed out the different kinds of hemophilias, but I think we need to just dive a bit deeper into the symptoms, the signs, how people present, and what we can do about it. So if I can go over to you, Megan, can you tell us briefly what made you start the Haemophilia Foundation? And then if you can then go on to describe the different kinds of symptoms that you found in hemophiliacs.
Thank you, Dr. Pamela, for having me. And thank you, Professor Akanmu, for that wonderful insight as usual. Why I went into hemophilia is because of the symptoms. I had a son who was circumcised as a 10-day-old and didn't stop bleeding and had to be transfused as a 15-day-old child. Fast forward 1 year, 9 months into birth, he has had 3 episodes of bleed, was eventually diagnosed to not having clotting time. And I was told that I just have to be careful with him. And his first 8 years of life, we depended on blood transfusions. And he actually had 7 blood transfusions in those first 8 years. And the fear of HIV becoming more predominant and other things made me to think there could be something else to do. I reached out to the World Federation of Haemophilia in 2004, and I got the first donation of 27 bottles of anti-factor coagulation. Used it, saw how well it worked, and I was told my son can't be the holy hemophilia. So April 17, 2005, we launched the Haemophilia Foundation of Nigeria with just my son. And next month, World Haemophilia Day, the organization will be 20 years. So that was why I started. So what are the symptoms we look out for? In persons who have the severe form of the disorder, you will actually see the symptoms within the first 1 year of life. It could either be if you do circumcision early from post-circumcision bleeds. If the child begins to crawl, you begin to see swellings and bruises on the knees, on the elbows. If you pick up a child, sometimes you might just see bruises on him. And these are the first signs you will see in the first early years. In the first 1 year of a child's life, all of this will present. And as a mother, you definitely begin to get worried and you can ask questions. If you have children with milder forms, they might not present in the first 1 year. They might start presenting when they start going to kindergarten, when they start going to crèche, and they bump into a table and you see a swelling. And sometimes you blame the person who is taking care of the child as not handling the child well. The child begins to run and play. He falls, he has a bleed. He falls, he has a cut, and the bleeding is not stopping. So generally, what we tell people is just watch out for bleeding. That's just it. It could be internal, it could be external. Just watch out for bleeding.
Now, if
So
we
that,
have, yes, if we
yes.
have people listening, we have mothers, we have grandmothers, we have carers, we have people just looking out and thinking to you, you know, I think I've seen this in my own. How can they reach out to you? How can they find, how can they come and join the Haemophilia Foundation to find out more?
The first thing when you have the symptoms is to get yourself tested. Diagnosis is always the first step. And for me, that's where I have a problem. Diagnosis is still expensive. So we reach out to some families, and when you tell them, the cost is a problem. So we're trying to see how we can bring down and make diagnosis, even if it's possible, free. But you have a child, you are listening to this program, or you have a family member, you are listening to this program, I encourage you to reach out to a tertiary facility where there is a department of hematology. A hematologist will be able to start the basic science, the basic tests. We'll get to a test to a level, and we can suspect, even without not going nitty-gritty into knowing the percentage of the factor, we will know if you have a bleeding disorders. As simple as a PT and an APTT can guide a hematologist into knowing if you need help.
If
So
we can
reach
just,
out.
yes, if we can just then jump over to you, Professor Akanmu. Can you take it from here so that we can understand a bit more about what needs to be done and how
Vegan
people
have
can
become
reach
an
out to people like you?
hematologist by association. Because what we just
Yes,
told you is what we call screening test. You do a PT
yes.
test, you do a PTT test. When PT test is normal, I won't describe the detail to you. An APTT test is normed. It means that individual is having a bleeding disorder as a result of coagulation problem that does not participate in the PT test cascade. And therefore, you can confine the abnormality to the cascade that is beyond PT test. And that means there are 4 proteins that you should be thinking of: factor 8, factor 9, factor 11, factor 12. We know factor 12 doesn't result in bleeding disorder. We know factor 11 is very rare. So if an individual is presenting with a bleeding disorder, PT test is normal, APTT test is prolonged, is either factor 8 deficiency or factor 9 deficiency. So we proceed and do what we call correction study or mixing experiment to decide which of these 2 factors is actually the cause of the bleeding disorder. So we carry out a mixing experiment, or what I prefer to call correction study. You will tell us, this is hemophilia A, this is hemophilia B, and that's it. If we have decided that this is hemophilia A, so we know how to manage. If we have decided that it is hemophilia B, it's a different line of management. But for either of the 2, we also want to determine, like it's telling you, an individual can present very early in life. It's more likely to be a severe hemophiliac. Or somebody is bleeding, severely into the viscous, it may be a severe hemophiliac. You have a clinical suspicion of severe hemophilia, but the confirmatory suspicion of severe hemophilia is that after you have diagnosed that this is hemophilia A or hemophilia B, you want to determine how deficient is this individual. If you categorize you as severely deficient, you will be bleeding too frequently and you'll be in and out of the hospital. If you are a moderate patient in terms of the level of your protein deficiency, then you will usually be bleeding what we call challenge bleeding. When you have hemorrhagic challenge, you are playing football, you are playing hard, then you can be bleeding. But if you are a very mild bleeding, it has to be a very, very serious surgical challenge that can actually make you to bleed. So we categorize the severity of deficiency. We say an individual is severely deficient when the factor level is less than 1% of what it should be. We say an individual is moderately deficient if the individual has between 2 and 6% of what the factor level should be. And we say an individual is mildly deficient if the individual has factor level between 6 and 40%. So if you have more than 40% factor level, it's very unlikely that you actually be bleeding.
Okay. Now, unfortunately, you won't believe this time is already up. And there's just so much more that we need to talk about. But I think we want to just talk a bit, if I can take it back to Megan, about the issues. You said there's such a challenge in getting the kind of factors that are needed for to help with treatment of these cases. So can you tell us a bit about that? And then I'm gonna talk to Prof about his own last words. These are going to be your own last words. If you can make the appeals that you need to make from this section. Megan.
Thank you, Dr. Pamela. Like Prof said, mild, moderate, or severe, and that determines what their treatment will look like. The standard of care is for every patient with hemophilia to be on prophylaxis. Now, because we depend 100% on donations in Nigeria, we can't put our patients, everyone, on prophylaxis. So we had to put children 0 to 12 years on prophylaxis and adults on on-demand. And on-demand treatment means that we only treat you when you have a bleed. And we're actually supposed to make sure your cup is half filled. Just have to make sure you're always full. That's what prophylaxis does. So the child can play, the man can go to work. But because it's donations, and I've always been saying it, this is my cry for 20 years, donations cannot last forever. And we cannot put the lives of our children on donation. A child wakes up, wants to go and wee, hits his head on the wall, is bleeding to the brain. You don't have factors. Everybody becomes helpless. Why? Because it's donations. If the donor says we don't have a right to question them. Now I'm holding 500 units of factor 8. This is 500 international units. And this one vial can only do prophylaxis for children under 5 years. Once a week injection on low dose prophylaxis. This bottle that I'm holding is about 700,000 naira.
Wow.
So how many families can afford? So we are calling on well-meaning Nigerians, we're calling on the government. Our main need now is even diagnosis. From tomorrow, 1st of April, we are launching a fundraising campaign, 100 days of an act of kindness. We're looking out for 1 million Nigerians that can make a donation of just 100 naira so that we can be able to roll out diagnosis freely. Prof talked about von Willebrand's disease. From the Federal Ministry of Health, 30% of postpartum hemorrhage, of maternal death is caused by postpartum hemorrhage. Women who have bleeding disorders have higher risk of PPH. And we're not diagnosing these women. We're not planning for their delivery. So we need to be able to run tests for Nigerians. He talked about 20,000 as our expected number. We have just about 887 on our records.
Yeah.
That means we have more than 19,000 Nigerians who don't know what they have, who have died. I don't want someone else to die the way my grandmother lost 9 sons. I don't want another woman to lose a child. Thank you.
Thank you so much. I mean, unfortunately, we have to go now, but I just want to ask Prof this last question. Prof, can't we produce these factors ourselves? As Nigerians, shouldn't we be looking into this?
I wish we were able to do so, and it's the way to go. Unfortunately, like Megan has told you, it's damn costly. I can just tell you that 1 unit of of factor 8 is approximately $1.
$1.
And if when you want to replace factor 8 in the deficient in the review, you want to just do 10% replacement, you probably will be needing between 1,000 units to 2,000 units. That means if you need 2,000 units twice daily, it means you need about $4,000 to treat daily for 5 days for the demand type of treatment that I just proposed to you. So it's a damn costly thing. So the science of production of factor 8 itself has to be looked into. So we have countries that are producing it, and we have people who really have the money, are pumping money there and are donating it to us. But if you are able to do so, it will be fantastic, because we should be able to have opportunity to sell it to other African countries, because hemophilia is not a respecter of any population. It's available in the same nearly proportion of population across all population. So everybody needs it. So if you're able to start to produce it, there's market there in every country.
Thank you. Megan, if you can quickly just give us a phone number that people can reach out to you if they want to donate.
Thank you, Dr. Pamela. The number is 080-3320-6779.
Please repeat.
080-3320-6779. Thank you.
Thank you. Thank you very much.
Thank you for watching. Please like, share and subscribe for new video updates.